Okie dokie. So yeah, let's get started then. Quick, good stuff. I hope you guys got it right. Very nice. Who did this one?
I think that was me. Yeah, so basically the radial nerve runs in the radial groove, and that is on the posterior side of the humeral shaft. And if you fracture that, you're going to most likely rip into that as well.
Look at that, Deepak already. Come on, whoever's got Carl McKinnon,
nice.
lift your game. But yeah, a few of these are going to be question and image because the text limit is really, really short for Cohort.
Nice. Well, so your circumflex humeral arteries, they basically provide blood supply to the humeral, the head of the humerus. So basically the proximal end of it. So it's nowhere near your condylar, which is at the distal end. And the radial vein is in your forearm, and it's a branch. It's a branch of the, I think, brachial vein as well, but that's further along, so it won't be damaged in a supracondylar fracture. So this process of elimination, the brachial artery is the only answer.
There we go. There we go. All the people who actually got the right answer, apologies in advance. It is supposed to be subscapularis, and I think you all know the anatomy. So if you got it wrong, that's okay. The main point of this is that you don't need to, or like the main principle I want to tell is that you don't need to know all the anatomical landmarks of every single bone, but some of them can be a bit more important. So if you're thinking about the attachments of all the rotator cuff muscles, remember that if you visualize it, the subscapularis is the only one that's sort of more the anterior side. So that's going to be the one that's going to attach to the lesser tubercle of the humerus, which is also more anterior. Whereas all the other three muscles and if you know all the rotator cuff muscles, that's fantastic. All the other three are going to attach to the posterior side, which is where the greater tubercle is. So that was the main point of this question. Good job, guys. One person got it right. Interesting.
Well, wrong or right. Oh, hello.
Oh,
there you go,
yeah,
Marsupial.
yeah.
Very well played.
All right, so this question is pretty buzzwordy. With the brachial plexus, you know that there's like a lot of those major branches which you need to remember, those 5 major branches. There are also a couple of minor ones that come off a little bit more proximally. You don't need to know all of them, I think the major one you need to know is just the one that causes this pathology. So you may have covered this in clinical skills. The long thoracic nerve coming off C5, C6, C7 nerve roots, that's the one that innervates the serratus anterior muscle. And the serratus anterior muscle is the one that keeps your, amongst other functions, it keeps your scapula really, really close to the rib cage. So if you get a patient to push against a wall, that serratus anterior muscle is not going to be able to keep the scapula close to the rib cage, which means it's going to jut out, and you'll be able to see that really visibly. I should have put a picture, but if you search it up, it should be somewhere. It's very, very visible. So good job.
All right, really great job, everyone. So we've already had about 3 questions so far about the humerus. So you can tell it's very, very clinically relevant. And so I think I've put in the chat as well, keep in mind what the effects of fractures at different points in the humerus do. I think you can really just focus on 4 main areas: the surgical neck, the midshaft, the supracondylar ridges, and the medial epicondyle. Have a look at those and see what nerves and arteries are impacted there. But with this proximal dislocation, which is at the glenoid fossa, you're going to have the humerus dislocating anteriorly usually, and that results in the axillary nerves being damaged. And that's why the answer is that one there.
I love that there's no explanation as to why I hit my elbow against a brick wall. It just did. You know, all
pretty
the other
self-explanatory, I think.
Exam revision is frustrated.
But for me, it's just, oh, I just need to revise this nerve, so I'm just going to hit my elbow against a wall and feel the region that it innervates.
It's practical revision, yeah.
I think anything with a name in it just helps people remember stuff. And I think putting Kyle in it is just going to make everyone remember it more. For this one, it is really well done, first of all. This one is kind of completing the story about what Janel was mentioning. So the different places which you can get nerves affected. This one's more talking about consequences in the medial epicondyle. So you know the ulnar groove. The ulnar nerve kind of goes or passes through that a little bit posteriorly before it then goes down into the forearm and the hand. And in this case, we're thinking about the sensory distribution. This is obviously very high yield. So remember that the ulnar nerve does the medial 1.5 fingers. The medial nerve kind of confusingly does the lateral 3.5 fingers. I think I said medial, it's median. And then the radial nerve does all the posterior sensory distribution. So this is definitely going to be the ulnar nerve.
All right, so we've got a bit of a split there, and it's an interesting question, this one. So I think most people, when they have a look at this question, they think extension, radial nerve, right? Because your extensors are mainly innervated by the radial nerve. But then you got to keep in mind that this extension is limited to only 3 fingers, being the thumb, index, and middle finger, right? So if those 3 digits are not going to be able to extend, it's probably not just to do with your broad extensor compartment, it's to do with some localized muscle group. And in this case, it's going to be the lumbricals. Lumbricals are the extensors that we often forget about when we talk about extension. And in this case, the extensors are going to be in those medial, also the lateral 3 digits, right? And the lateral lumbricals are innervated by the median, the median nerve, right? So just keep that in mind as to why that's the answer for this question. Again, keep in mind if you had ulnar nerve damage, you'd have the same thing with the lumbricals on your medial side, right? Okay.
So yeah, if you had radial nerve damage, I'm not sure if you said that, Janel, but if you had radial nerve damage, then it would be more extension. It wouldn't just be the extension of those digits.
And the buzzword for radial nerve injury is usually just going to be wrist drop, because you're not going to be able to extend at the wrist. And so you're going to have your hand in that wrist drop position.
Yeah, nice. Well done. So this is definitely going to be axillary nerve, just because there are sort of two major nerves that are going to be helping with abduction. For the first, I think 20 degrees or 15 degrees, it's going to be a specific muscle in the rotator cuff. Does anyone know what the name of that muscle is? If anyone wants to put it in the chat. So this only does the first 15-ish degrees. Yeah, perfect, supraspinatus. And I think for extra points, does anyone know the nerve that would innervate supraspinatus? Yeah, fantastic. So I've got a couple of people saying suprascapular nerve. So that obviously has nothing to do with any of the terminal branches, right? We're talking about all the terminal ones here. I think suprascapularis or the suprascapular nerve will come off much more proximally. So in this case, we're actually thinking about the deltoid muscle. So that's the one that's going to help the suprascapular, sorry, the suprascapular muscle is very confusing. The suprascapular muscle after the 15 degrees, just because the deltoid muscle is much, much stronger. So that's why he can't get it up to a vertical position in this case. Well done.
Yeah, I think usually we think of supraspinatus as being the helper that gets you up to that range because your deltoid is doing basically the rest of it. But yeah.
Fantastic. Really, really well done, guys. So in this case, remember that with your spinal cord, it's going to end at a specific spinal level. Does anyone know what the spinal level is at which the spinal cord we generally say ends? So yeah, generally it's going to be like there's a couple of things you can think about. Generally, the conus medullaris is sort of at around the L1 level, and then it'll continue downwards as like the chorda equina and all that stuff. So you can still damage the chorda equina if you were to put in a needle, but that's going to be a lot less consequential to the patient in terms of sensory and motor deficits, as opposed to if you were to go higher. So there's actually a couple of sources online that say like you can go L3, L4 or L4, L5. I put L3, L4 just because I think I saw that in an exam. That was the answer that they gave. But I do see why a lot of people have also chosen L4, L5. I think this year we learned it was more the yellow. So I think this is more of a learning point that you don't want to pick red. That would be too high up. And S2, S3 is not actually a vertebral level. That's more the sacral region. So you wouldn't actually have a gap in that space. So that level wouldn't be like anywhere near where the end of the spinal cord is. So in this case, if you chose blue or yellow, that's really good.
And the sacrum isn't lumbar, so it wouldn't count as a lumbar puncture anyway. You'd be breaking the sacrum.
Yeah, fantastic. So in this case, I think the answer is pretty much just one word. So there's not really much to explain. It's going to be between the arachnoid mater and the pia mater underneath. We call that the subarachnoid space. That's the only actual space that you have. So in other words, that's the only space that's actually filled with anything. The epidural space is filled with fat, but we still call it a potential space. You don't want to see that space being like, if you were to look at an X-ray or a CT scan, you wouldn't want that area to be kind of increased in size. That would indicate some sort of pathology. Same with the subdural space. Spinal canal obviously is not going to contain, it's not a meningeal space. It will probably contain CSF, it's just not a meningeal space. Good job. So the answer is subarachnoid.
Sweet. So this one's just a buzzwordy question for you. It's just something you got to remember. It's just that if it's talking about the web space between the first and two digits of your feet, it's always talking about the deep fibula in terms of sensation.
All right, so this question is pretty much just understanding that your deltoid is the medial ligament on your foot and your anterior talar fibula is on the lateral side, which kind of makes sense because your fibula is on that lateral side of your foot as well. And with this one, again, it's the sort of thing you have to know that injuring an inversion injury, ankle sprain, is more common than an eversion. And so that's why inversion is going to be the answer here. And then the associated ligament, which is going to be damaged, is the one on the lateral aspect, which is the anterior talar fibula. So I think it should be yellow here, but yeah, for those of you who got red, unfortunately, you'll also get the right marker there as well.
Yeah, a key point there as well is that you have like your ATFL, your I think your calcaneofibula, and your PTFL. And so those are all like thin bands on the lateral side of your ankle, if we imagine this is the lateral side of your ankle. And your ATFL is the most likely to be sprained. And the reasons are twofold. One, it's a much thinner band than that sort of thick band of deltoid on the medial side. And also, because of the way that your center of gravity goes, you can't actually catch yourself if you're falling outwards. Whereas you can catch yourself if you're falling onto your other leg, right? So yeah, there we are. We just like to reward some incorrect answers sometimes. I think it's a little bit more fair.
Keep you guys on your toes, basically.
So I don't think the edits have come through. The final one is supposed to be posterior ligament, but
Yeah,
people put their answers in already. Anyway,
yeah. No, might not say it properly. That's my bad.
Yeah, I'll try to explain it and hopefully it makes sense why the answer is what it is. Technically, all of you are correct because all of these are right answers. The last one was supposed to be, as Kyle mentioned, posterior cruciate ligament, which is going to be the right answer. So this basically refers to the unhappy triad or blown knee, right? And what's happening here is a lateral blow to the foot, a planted foot usually, and that's referred to as a valgum force, right? Or valgus force. And what's happening there is you're having a lateral blow, which means that you're going to be bending your knee joint inwards, and that's going to result in a stretching and breaking of that medial ligament, which is your tibial ligament. So that's why you have your torn tibial collateral ligament, and you also have an associated tear in the anterior cruciate ligament and the medial meniscus. I'm not too sure why they specifically are torn, but it's just the sort of triad you associate with a blown knee.
I think the major reason is just because they're all sort of fused together, or at least very, very close to each other. So I think you guys remember back to our lecture on lower limb and the ligaments of the knee. You'll remember that on the medial aspect of the knee, when you've got the so the tibial collateral being just the medial collateral ligament, that one is fused with the medial with the what's it called? I just had a mind blank.
Medial collateral?
Medial collateral is with the meniscus, sorry, the medial meniscus. Yeah, I had a mind blank, I don't know why. So they're both fused together. On the lateral side, they're not actually touching, right? So if you were to have a damage to the lateral collateral ligament, you wouldn't really have too many concurrent problems happening after that. In this case, you'll have 2 damages, and then because those 2 ligaments are already weakened, you will have a 3rd injury. And so if you want to look at the mechanism of all those, that's awesome. But just remember those 3 ligaments as being sort of paired together when they get injured.
Yeah, and noting meniscus, I don't think is technically a ligament, but yeah.
Oh, I'm kind of happy that I trapped a couple of people with red, because that is almost right up until the very end. So I might just walk through all of the options. In this case, remember that when you're thinking about blood supply to the femoral head, it's kind of like a retrograde supply. Any bone that has a sort of retrograde supply to it is going to be at risk of avascular necrosis if you damage the vessels more proximally or more distally, depending on what limb you're talking about. So in this case, with the hip joint, you've got the retinacular arteries that come off the medial and lateral circumflex, similar to what happens with the humerus more proximally. In this case, the retinacular arteries will climb up the head of the femur and then supply that. You've also got like a couple of more minor supplies. I think the obturator artery also helps a little bit, but for the most part, the most blood supply comes off those retinacular arteries. So those retinacular arteries in terms of location are going to be within the capsule. So anytime you see a question that has extracapsular, I don't think there's actually going to be too many repercussions apart from potentially obviously there's damage, so risk of osteoporosis, things like that. But in terms of blood supply, it's the intracapsular ones that are going to be the most damaging. And red is incorrect because that says femoral shaft, not femoral head. Femoral shaft has a slightly more distinct blood supply. Yeah, so I got a question. Green would be correct if it said intracapsular. So again, green is absolutely everything's correct except for that first word. That's the only thing. Okay. Well done, guys. A bit of a trick question. They won't be this mean in the exam, I promise. It'll be a bit more obvious, I think. Yeah, well done. Okay, so the pes anserinus muscle, or the tendon, is not like that clinically relevant unless you're thinking about like bursa underneath the tendon. For the most part, it's more anatomically relevant and more so for exams because there are 3 tendons that kind of come into that one fused tendon, and they all come from 3 different compartments, which makes it anatomically really interesting. I think if you are really struggling to remember which of these muscles contributes, just remember the mnemonic say grace before T. That's what I used and it kind of helped. So say being sartorius, grace being gracilis, and then T. T is kind of to make you remember that it's the tendinosus, not the membranosus muscle. And membranosus will not contribute. Extra points if you can think about which compartments they come from, because that could be something that they like might put into the multiple choice. So remember, sartorius is at the front, gracilis is going to be more medially, and then semitendinosus is going to be posterior. Good job, guys.
All right, great job, everyone. I think this time the question has the right answer, so I'll try and explain this one. So again, we are having a look at valgus forces and varus forces. And in this case, the valgus forces, again, if you remember, it's going to be moving your knees inwards. So it's a lateral force coming in medially. And in this case, it's going to be stretching your MCL, so you're going to damage your MCL. And the opposite way around, if you're pushing your knees out with that force, it's going to stretch out the LCL, the lateral collateral ligament, and cause damage there. Yeah, that's basically it for that question.
Straightforward mnemonic for valgus versus varus is thinking about the letter L versus the letter R. Think of like two letter L's knocking knees. So that's the medial part. And think of sort of R's, that curved part of the top part of a capital R, as being sort of bow-legged, so outwards. So stressing that lateral component.
Or if you're like me and forget your basic alphabets because of how stressful these exams are, just remember valgus being valgum, so gum fusing your knees together. All right. Okay, so this one's a little bit trickier. Just bring it back to basics. And I think this question is, it's not a common one that they'll ask. It's kind of, the reason why I designed this question is it's the opposite of something you've learned. So remember we talked about the thoracotomy needle. There's a particular place you don't want to put that needle because it'll damage a particular nerve. In this case, we want to actually target that nerve because it'll allow us to anesthetize a dermatome. In this case, I've talked about the T4 dermatome. And so we're already thinking like, what's the fourth intercostal nerve? And remember that underneath each of the nerves in their costal grooves, underneath each of the ribs in their costal grooves, you will have the Van bundle. The nerve is the only one that really sticks out. Everything else is really, really well protected. So in this case, if I want to get that fourth nerve to be anesthetized, I need to go between the fourth and fifth rib. And I want to go underneath the fourth rib, which is basically the top part of the fourth intercostal space, which is between the fourth and the fifth rib. Does that make sense? I know it's a bit confusing, but remember, fourth intercostal space is between the fourth and the fifth rib. And so if I was to go on the top aspect of that space, I would be looking at the fourth intercostal nerve and anesthetizing that. Hopefully that makes sense. If there's any confusions, let me know.
So I think the idea is we're trying to target the nerve. So we'd be very careful about it. We wouldn't just be sticking it in there.
Yeah, true. You don't want to.
Yeah. But as Jane was saying, yeah, I think the idea here is we're saying we're trying to target the nerve. So you need to go where the nerve is, not where the nerve isn't. But yeah, it wouldn't be like a thoracostomy where you're trying to get through to the pleural cavity or something like that. Trying to get just into the.
Yeah. Now that's a really, really good point. You probably don't that's a good point. So clinically speaking, you don't want to like pierce that nerve because then you're going to cause irreversible damage. But I think it's just the anatomy part of it, not so much the clinical repercussions. Of course, you care about the patient. You don't want them to have any permanent damage. In this case, it's again a straight up anatomy recall. So each of the diaphragmatic hiatuses, remember that if you're struggling to remember, this question didn't really ask about the levels, but if you're struggling to remember there's that mnemonic you can use, like the number of letters in each of the names. In this case, it's more about the contents, which is more likely to be asked about. I think if we run through each of them, can someone tell me where do you think the right phrenic nerve would be going through, if not the esophageal hiatus? Yeah, so I'm getting the vena cava. Yeah, fantastic. So it's going to be the caval hiatus. What about the internal thoracic artery? Does that go through any of them? And so that one's a bit of a trick. It doesn't actually go through any of the hiatus, so that's not correct. And the caval hiatus, the superior vena cava doesn't go through it. It's the inferior vena cava. Now with the esophageal hiatus, oh, that's a typo. It should say vagus nerve, not azygous vein. That's my bad again. Apologies. I'm going to correct all of these afterwards. I really, really apologize. You're right. I think everyone's been spamming me with messages. You're all correct. So azygous vein travels through aortic. And the way I like to remember it is a lot of the blood vessels will go through that aortic hiatus. The only blood vessel that really goes through the, like another hiatus, is the inferior vena cava, if that's one you want to remember. The esophagus is really straightforward, or the esophageal hiatus, because it only contains the esophagus and the nerves that correspond to the esophagus, which is the vagus nerve or the vagal plexus, which you'll learn a little bit more about in gastro next year. Oh man, sorry about that, guys.
So I think if there's any additional knowledge we're learning from this, it's don't create questions at midnight straight off the top of your brain. It'll get a bit messy.
Oh, this is mine too. Okay. Fingers crossed there's nothing wrong with this. You guys, I think most of you got it right, so that's fantastic. Remember that if you forget everything about thorax, just remember that for the transthoracic plane, it's always going to be at the T4, T5 junction. So it goes all the way from your second rib at the front. And remember how you can palpate sort of where the second rib is on a patient. You know, there's that little bump, right? The sternal angle. And if you follow that all the way back horizontally, you should end up at the T4, T5 vertebral space. So that red is going to be correct. The other things are more recall questions. I tried to be a bit tricky with green because it's not the origin of the pulmonary trunk. It's actually the bifurcation of the pulmonary trunk. So there's two bifurcations, the pulmonary trunk and then the trachea. Pulmonary trunk kind of goes from bottom to top and bifurcates. Trachea comes from top to bottom and bifurcates. The other ones are just recalls, so azygous vein draining into SVC, other things. If you're struggling to remember, just remember the rat plant mnemonic, which should be on the slides. Well done. Well done. You guys are on the money. So again, red is just there as a bit of a trick. The left side is not where the liver is. The right side is where you would find the liver. So that's why normally when you see a chest X-ray, if you do notice that the right hemidiaphragm is a little bit higher, you shouldn't be too concerned unless it's obviously pathologically higher, just because the liver is a massive organ that's going to push up on the diaphragm from there. If you have damage to either phrenic nerve, remember the phrenic nerve is going to innervate both sides of the diaphragm, so each of the hemidiaphragms. If the left phrenic nerve is damaged, your diaphragm is not going to be able to contract or relax, which means, or like I guess the more important one is it's not going to be able to contract. So it's actually going to be a lot higher than the one on the right, or at least not at the same level, which is not normal. The right vagus nerve is not to do with the diaphragm. The last two I kind of just made up. So the right vagus nerve, if you had damage to that, you'd probably notice a lot of stuff like heart rate jumping or something like that. And abnormally enlarged left ventricle is kind of random. That wouldn't cause any, that would, if anything, push the diaphragm a little bit more further down because it's on top of that. So well done.
Too easy. Everybody's an anatomy god. So basically the left recurrent laryngeal nerve runs under the arch of the aorta. And if you are having a cardiac surgery, there might be some damage to that nerve if there was some stretching or maybe even a cut to it. And that innervates muscles of the throat, and therefore you get that hoarse voice.
Oh, I was expecting more of a split with this question, but that's really good. Does someone want to tell me, when I say left heart dominance or right heart dominance, which artery am I kind of talking about, if that makes sense? Which artery is being supplied by either the left coronary or the right coronary artery? Yes, fantastic. So I've got a couple of people saying the posterior descending or the posterior interventricular, they're kind of interchangeable. In this case, if we have a left dominant heart, not only do we have the anterior descending or the left anterior descending coming off the left side, we now also have the posterior descending or posterior interventricular artery coming off the left side, which means if I have some sort of occlusion to the left coronary artery, I might risk my entire septum, which is what those arteries are supplying for the most part, becoming ischemic, which is definitely not good. There's no collaterals going to that part of the heart. The other ones, again, I just sort of made up. Left coronary perforate doesn't have anything to do with it, and the ventricles, nothing to do with hypertrophying, and dominance has nothing to do with nerves. It's more to do with the vasculature. So really well done. It's a very, very high yield concept, so keep that in mind for the inevitable one question you get on it.
One of these answers is very easily eliminated.
I'm very disappointed. I'm very disappointed in the one of
Amazing.
you that picked
Amazing.
tricuspid.
That's incredible.
Okay, yeah, so I'll jump in with why the answer here is mitral. So again, all you have to know here is that basically you have the 4 heart valves. They're either going to have 3 leaflets or three cusps, or they're going to have 2 leaflets, right? And in this case, there's only one that has 2 leaflets. And the way you can remember which that one is, it's the only valve which has 2 syllables in it. It's just a very small niche thing you have to know. Everything else has 3. So just keep that in mind, and you should be solid for that question. All right, so again, for this one here, the answer is diastole. And the reason is that during diastole, your aortic sinuses, which is in your aortic valve, can actually fill up, and that allows your coronary arteries to fill as well. So that's just another thing, anatomical thing you got to keep in mind, that your coronaries, they actually originate from your aortic valve. And so when your valve is closed and shut, they can actually fill those sinuses and fill up those coronary vessels. All right, so with this one as well, it's going to be parietal and visceral pericardium. And the way you can remember this one in terms of the order of the layers going in is it's kind of an alphabetical order. So you have fibrous pericardium on the outside, so that's the F there. Then you have parietal pericardium, which is P, and then you have the visceral pericardium. So you're going, in alphabetical order there. After that, it gets a bit different. Like you have the myocardium, but that you can just remember that as being the actual muscle tissue of the heart itself. And then you have the endocardium, which is that layer surrounding the inside of the heart. So the outer three layers, the pericardium, they follow that alphabetical order, but then after that you have the myocardium and endocardium. And in this case, it's between the parietal and visceral layers that we actually have a potential space that can form, where fluid can build up and that pericardial effusion can occur.
You can also relate this parietal and visceral distinction to when you're talking about the pleura. So visceral is something that's closer into the organ to the viscera, and parietal is a layer out.
All right, I've successfully shaken things up a bit. So in this case, you don't like, it's not the most high yield thing, I'll admit, but it's a good idea just to know, like if you know what each of these mean, then you might be able to tell whether something is going to cause the mixing of deoxygenated blood with oxygenated blood and then therefore cause cyanosis peripherally, or whether it's not going to do that and therefore be acyanotic. So generally for most of these congenital heart disorders, they are going to be cyanotic. So like I can take an example, probably the easiest one to explain, the great artery transposition. If you've got your pulmonary trunk and your aorta swapping around, that will mean that the aorta is going to receive deoxygenated blood. So that is why you're going to get, that is why you're going to get cyanosis. The other ones, again, you can have a look at. Tetralogy of Fallot is a nice one. I think there was a mnemonic for that. But just remember, you don't have to remember the steps too much. It's more about the fact that it causes cyanosis. With ventricular septal defect, that one is a bit more niche, or I think atrial septal defect would also be very similar, because what happens in the adult is you have a increased left-sided pressure. So when you have increased left-sided pressure, even if you have that septal defect, what will end up happening is that the oxygenated blood from your left ventricle will end up going into the right ventricle, rather than deoxygenated blood going from your right ventricle into your left ventricle. The latter thing that I mentioned is going to be what causes cyanosis, because you've got deoxygenated blood entering systemic circulation. In this case, you've just got more oxygenated blood entering the pulmonary circulation, which won't cause cyanosis. So again, it's very complicated. I would encourage you to, I think you guys have had a lecture from Michelle on congenital heart disorders, and there was a couple of diagrams you could draw to kind of visualize why some of these will cause mixing and which won't. So just have a look at that, revise that concept again, and you'll see why the septal defects are less likely to cause cyanosis. Cool.
Yep, so good job, guys. It's going to be red and blue because those are the roles of the supplementary motor area. Don't forget that you've got your premotor area as well, which uses the sensory input to guide motor action. So that's yellow. It's going to be premotor, not supplementary. And the primary motor cortex is really green, executing movement. Okay, so yes, group 1A is going to be for innervating muscle spindles. Group 1B, however, is going to be for the Golgi tendon organ thingy in the tendons, which is for tension. The muscle spindles for stretch. So just remember that those two are different. Group 2A and 2B are just not real. I just made that up. So good work. Good work. Okay, so Janil pricks himself with a pin. So that's going to be a noxious mechanical stimuli. And we know that delta fibers are going to be myelinated, and that helps us differentiate between C fibers and delta. So we know that the first response to stuff is going to be from A delta fibers. For type 1, that's going to be the first response to mechanical sort of pain. And type 2 is going to be the first response to nociceptive heat. And nociceptive C fibers do both mechanical and temperature-based pain, but it's just not fast enough. So since it's unmyelinated, which makes the answer type 1A delta.
Apologies on that one there. All of the image ones were meant to be 30 seconds to give you guys more time, but that one slipped through.
Yeah, so kind of disappointing. 6 people put green, but we'll look past that. For this question, in terms of the autoregulation, you have 2 main mechanisms, which is metabolic and myogenic mechanism. And the thing is that the myogenic mechanism is going to be local. So wherever there's stretch of muscles, your muscles are going to automatically want to contract back. But for metabolic control, that is literally wherever you have an increase in things like carbon dioxide, decrease in oxygen, increase in H+, decrease in increase acidity. So because that sort of metabolic stuff is not specific to muscles, it can be seen in all tissues. But obviously, it's especially important in skeletal and cardiac muscle.
This one's worded a little bit weirdly. If it has a diameter of 1 and it was going to double in diameter, what's the resulting change?
Nicely done. Yeah, the question wording was a bit scuffed, but yeah, we'll move on from that. So basically the idea was if the vessel size was doubled, if we remember our equation for resistance, which equals to 1 over our radius raised to the power of 4. So if we double it, it's 2 raised to the power of 4. So we get 1 over 16. So therefore it's decreased by 16.
People still figured out what you were asking, Raymond. Good stuff.
Yep, good work to those who got it right. It's a little bit tricky. It's kind of niche in the lecture, but it is what it is. It's true. Not much explanation there, though.
My guess would just be that if you're a smaller arteriole, like it'll be more likely to hit you or something. I don't know. What's your thoughts, Deepak?
I think it's like those couple of experiments done, which just showed it experimentally that it affected small arterioles more. Not sure physiologically how it works though.
All right, good job. So I know it's a bit of a, I know it's a maths question. It's not very exciting, but remember that in exams, they usually will not make your like maths have to be like too difficult, just because I don't think you are given a calculator or allowed one. So just remember that it won't be like if I put 112, 119, it's generally not going to be those ones. But if you want the formula, just remember that the easiest way to remember it is you take the lowest number, the 90, and then add 1/3 of the difference between the highest number and the lowest number. In other words, the diastolic blood pressure plus 1/3 of the pulse pressure, which is the difference between both of those numbers. So in this case, it would have been 90 plus 1/3 of the difference, which is 30. So 90 plus 10, therefore 100. All right.
All right, very good. I'm glad to see it. That the blue should say atrial contraction, not aortic contraction. There's probably something else going on if you've got aortic contraction. So the heart sounds are both the result of valve closure. So if you think about it, like, you know, when you move your muscles, that doesn't actually make much sound. And certainly not enough for you to hear it in an appreciable sense when you're auscultating the heart. So what they actually are is valve closures. So the first heart sound, the lub, is your atrioventricular valves, your tricuspid and your mitral valves, closing after shunting all that blood into the ventricles. Okay, so it's the step that seals the ventricles in preparation for systole. So that's the first one. And then the second one is after we have systolic contraction, the ventricles contract to push all the blood into the circulation, the aortic valve and the pulmonary valve both close. So the first heart sound is both tricuspid and mitral. The second heart sound is both aortic and pulmonary.
Yeah, and the way to remember that heart sounds are from valve closure is to think of like doors slamming. You don't really like open a door loudly. You don't really move a door loudly unless it's a squeaky hinge. But you slam a door and it's going to be very loud. And the reason that valves close is because of the pressure difference. So once the pressure in the ventricles builds up and it's greater than that in the atria, then that's going to push back on the atrioventricular valves, causing that first heart sound.
All right. So, good work, guys. Allopurinol is a xanthine oxidase inhibitor, drug of choice for chronic use. Probenecid inhibits excretion of uric acid. Increases uric acid excretion, again, for chronic use. Colchicine is for leukocyte, reducing leukocyte migration to the site of inflammation, again, for chronic use, but also used in acute gout attacks and NSAIDs. Keep in mind that it's also used in acute attacks and sometimes in chronic use, just for general anti-inflammatory effects. Ooh, kind of split. So the reason why it's Tramadol is because it's a serotonin and noradrenaline reuptake inhibitor, and it actually causes analgesic effects because by inhibiting the reuptake of it, we increase the amounts, and that inhibits nociception at the dorsal horn. So it kind of acts like a like an opioid kind of. And since it increases serotonin, nausea and vomiting is pretty likely because it acts at those centers in the brain. Loperamide is an opioid agonist, but it doesn't cross the GIT since it is poorly absorbed, so we wouldn't see central effects like nausea, vomiting. Naloxone is an opioid antagonist, not an opioid agonist. Diazepam is a benzodiazepine, not super relevant here. But yes, that leaves us with Tramadol. One other thing is that just generally, opioid analgesics do have nausea and vomiting as a side effect. So if any other opioid analgesic was in the options, we would be thinking about them. But Tramadol is our best answer here.
All right, Carl says pharmacology is hell. I tend to agree. So congratulations to a lot of you guys on getting this one right. So gemfibrozil is a fibrate, so they act on PPAR alpha receptors, and they basically mess with the production of VLDL in the liver, and they also increase the uptake of LDL. So that's their mechanism of action. Atorvastatin is a statin which messes with HMG-CoA reductase. And that's the method of stopping cholesterol synthesis in the first place in the liver. So it's not doing anything to PPAR alpha receptors. Ezetimibe is a cholesterol absorption inhibitor. So it's going to block a transport protein to prevent like your hepatocytes and whatnot, and your fat cells in general from taking up cholesterol. And cholesterol is a bile acid binding resin. So it's going to bind to just your bile. So the rest of them don't have anything to do with PPAR alpha receptors. All right, I'm very glad most of you guys got this one correct. So when we talk about the sort of anti-muscarinics, we talk a lot about anti-SLUD effects. So SLUD stands for salivation, lacrimation, urination, and diarrhea. And so those four things are linked to normal muscarinic function or muscarinic agonist, okay? And so if we were to give a patient a muscarinic agonist, we would expect those things to happen. Now, atropine is a muscarinic antagonist, so it's going to do the opposite. So we have anti-side effects. So you have less elevation, you have less lacrimation, and you have constipation, if anything. And now the other thing that muscarinics do is they retract. Should really know the opposite of dilation.
Constrict.
Constrict. That's the word. Thank you. They constrict the pupils, and so if you give an agonist, it's going to constrict the pupils, whereas if you give an antagonist like atropine, it's going to dilate the pupils. So when we say like photosensitivity, so like people on atropine might be more sensitive to light, it's because their pupils are more dilated, so that everything seems brighter to them, basically.
Also, if you just want a slightly easier way to remember this, just remember that if it's an anti-muscarinic, it's anti-parasympathetic, which means it's going to be more sympathetic. And if you look at the options, remember sympathetic is like your flight and fight. So do you want to be crying more when you're running from something? Probably not. Do you want to be salivating more because you're hungry? Probably not. Do you want to be going to the toilet a lot more? Probably not. The thing you want to be doing is opening up your eyes so that you can see the bear that's running towards you or whatever. So that's why that would be the correct answer.
Yeah, that's.
But yeah, SLUD is also good.
Yeah, no, that's a perfect way to understand it.
Alrighty. So I'm glad that the fewest number of people picked creatine kinase MM. So thinking about cardiac biomarkers, cardiac troponin is our gold standard one we always talk about when we think about heart attacks, very specific to the heart. Creatine kinase MB is the isomer of creatine kinase that is pretty specific to the heart as well. Something a little bit more niche is the brain type natriuretic peptide. It is released mainly by ventricles upon ventricular stress, but it was initially found in the brain, which is what we call the brain type. But technically, you can make a case that it is specific to the heart, much like the atrial natriuretic peptide. So that is that. The MM is seen in all muscles, I believe. It's not specific to the heart anyway, so it's not going to be yellow.
Something interesting I heard in the year 2 revision recently was that because your cardiac troponin is elevated like the highest about 7 hours or so, I think, after your first heart attack, but it stays pretty high in the blood for like 2 weeks. So it's really, the CKMB, the creatine kinase MB, is really useful for distinguishing if they've had a subsequent ischemic attack to their heart, while, say, they're still in the hospital. If you did measure their troponins, you might just be like, oh, yeah, it's because they had a heart attack 3 days ago. But no, they might actually be having another acute infarct, and that would be due to, and the way that you could tell that would be through another sort of acutely elevated CKMB.
Ooh, okay. So the thing about angina is we want a beta-1 antagonist. So we want to ideally use atenolol since it's specific to beta-1. Propranolol is non-specific, however, so it does both beta-1 and beta-2 antagonist. And the thing is, beta-2 antagonism can cause vasoconstriction. So it is not super helpful for us, or it's not usually useful for us in angina, since coronary vasoconstriction will lead to more pain because you're inhibiting coronary perfusion. Good work, guys. So that's atenolol is the beta 1 antagonist I talked about just then, and verapamil is going to be a calcium antagonist. And both of them provide a bradycardiac effect, and combining them would lead to an additive effect, which is pretty contraindicated, especially in the case of heart failure. Good work, good work. So the idea behind this question is basically digoxin, the mode of action of digoxin is inhibiting sodium potassium ATPase, which is going to help us decrease sort of the cardiac contractility stuff. And in a hypokalemic state, that will cause lesser competition for digoxin when you have lesser potassium. So digoxin would have an excessive effect. And we see this hypokalemic state in a potassium sort of sparing diuretic. I mean, without a potassium sparing diuretic, like furosemide and hydrochlorothiazide, those diuretics would lose a lot of potassium. So you would have excessive digoxin action, but spironolactone's okay because it's digoxin sparing, I mean, potassium sparing.
One of the loveliest buzzwords.
All right, good work, guys. Perindopril, ACE inhibitor, and ACE normally breaks down bradykinin, so we'd have excess bradykinin, dry cough.
Which is when you switch people to ARBs instead, which have the suffix sartan.
Yep.
I hope I haven't ruined any Defect's subsequent questions.
No, I don't think
You're
so.
all good.
Yeah.
Yes, okay. Does anyone know the other name for this particular medication that you want to avoid? Yeah, fantastic. So you don't want to be administering a GTN spray with Viagra or sildenafil, because I believe they both cause a massive increase in cyclic AMP within those cells. And so, like, again, similar to what Deepak was saying, it's like an additive effect. You don't want too much of something that's good. The other medications are actually kind of either random or they can be used for a particular pathology, but it's not related to anything to do with GTN spray. By the way, GTN is just like nitrates. So you guys have learned about nitrates already. Good work.
Okay, we've got a bit of a split here, but let's have a look at the answer for this question. So this question was about someone who'd fallen from a tree and then they had their hand stuck in a claw shape. And so the question is, what's the mechanism of injury and what's been damaged and what's the effect that's happening here? So we know that they recalled grabbing onto a branch during their fall, right? So that might explain the mechanism of injury. They're grabbing onto a branch and there's some sort of damage. Now, usually with this sort of grabbing onto a branch and falling, that's sort of a buzzword for Klumkos palsy, where you have excessive upward pull of the limb, which stretches the nerve roots, which are lower down in the brachial plexus, so C8T1. And because of that damage, you're going to have the effects that are described there with the claw hand. And the way that I remember it is that C8T1 is a lower nerve root, and that's why you have Klumkos being affected as opposed to herbs, because Klumkos later on in the alphabet, the K there. And you've got the claw there because of, again, the K in Klumkos, or you can also remember that as the C8T1 as affecting more distal areas, whereas the herbs palsy, which has C5, C6 damage, is going to be higher up and affecting more proximal areas, which is the arm and wrist, where you get that wader's tip. So yeah, the answer here was Klumkos palsy, and I think that was, and I think, yeah, with herbs palsy, it would be normally something where you have an increase in the angle between your neck and shoulder. And that's sort of the mechanism of injury there, which would more impact the C5, 6 areas, nerve roots.
Just to add, for all the people who put ulnar nerve damage, you are technically correct. Klumkos palsy is going to be those lower nerve roots, C8T1. So the reason why you do see that claw hand is because of the ulnar nerve damage. But I think in terms of what this question is going for is more like the most accurate diagnosis in that case would be Klumkos palsy.
Yeah, the damage here is happening at the root level usually, which is why we say Klumkos palsy rather than more distally at the peripheral nerves.
Awesome. So this is another buzzwordy question. So it's anatomical snuff box, and that's always related to your scaphoid. Bonus mark, can somebody tell me why we care about the scaphoid? Or the most common complications due to it? Yes, perfect. Avascular necrosis due to the retrograde blood supply to the scaphoid bone. Awesome.
Okay, so we've got a bit of a split here again, but most of you have gone for 2 there. So I'll explain what muscle power really is. So again, we grade muscle power on a 5-point system. So 0 is just where you have no movement at all, complete paralysis. So you're not going to have any signs of movement at that limb or that joint. 1 is where you see some contraction occurring, but not enough to move the actual muscles at the joint. 2 is where you can move the muscle, but it's only when gravity is eliminated. So think about in the horizontal plane, which is happening over here, where you have the patient on the side, and that way gravity is not acting against the movement, but is acting perpendicular to it. So it's still able to sort of perform that movement without gravity affecting it in any way. 3 is where you can move against gravity, but not resistance. So you're able to actively contract that joint, but you're not able to do the same when someone pushes down on it. If you can do when someone pushes down on it as well, that's called a power of 4. And power 5 is just normal, where they're able to perform all of the actions without any sort of problems there at all. So yeah, in this case, what's happening is that I think it was John. Yeah, John suffered sort of difficulty moving his right arm and his right elbow, and he's only able to perform that movement of flexion when gravity is eliminated, when he's lying on his left side and gravity is no longer in the plane because he's moving horizontally, right? And so that's why we gave the power as 2.
All right, so Sam injured the most commonly injured knee ligament in a sudden twisting motion, and which test would have a positive finding? These 4 that we have here. Beautiful. All right, so most people have gotten that. Yeah, so Lockman's test is one of them. The other test that we might expect to see affecting this ligament, what would that be? Can anyone message me it, bug me it in the next 5 to 10 seconds? Yes, ant draw, beautiful, anterior draw test. Yeah, so we're testing the ACL. The ACL is what's been injured here. And so, yeah, the Lockman test and the anterior draw test the ACL. The posterior draw does the posterior cruciate ligament. The varus does the lateral collateral, and the valgus does our medial collateral. Beautiful. So I'm pretty sure the correct answer is going to be wrong here.
Yeah.
Seeing
I think
that
the
our
answer still holds, but it just doesn't make as much sense with what's being said. We'll take a look.
yeah, it's well, yeah. So rip to your streaks, rip to your points, but being correct is more important than being rewarded for being correct.
Yeah,
we'll
life
try and
lessons.
salvage
We're
it.
teaching you life lessons, guys.
Okay, that's definitely wrong then. So let's have a look at this question and sort of explain what's happening here. James, could you show the media again? Okay, so the answer is wrong, but we'll explain what the right answer is. So there's got intense pain on the outer part of his elbow. So that's going to be, again, the lateral side. So it's obviously not going to be medial epicondylitis. So not going to be orange or green here. And the mechanism, however, is a bit misleading. So we'll talk about what's happening. So we've got medial epicondyle being involved, right? And with the medial epicondyle, it's where the common flexor origin is for those flexor tendons in your arm. And so what's going to happen is if you damage that area and you have micro tears in the muscles that come off there, you're going to have difficulty flexing your arm. And so that's why you're going to have, oh, I think I'm saying the wrong thing there. Let me go back a step. I said lateral epicondylitis. So you're going to have damage to the extensor compartment where all the extensors are going to be acting, right? That's why you're going to have difficulty when you're resisting extension. So the answer should actually be blue here, not orange. And also the mechanism is kind of misleading because golf is normally associated with medial epicondylitis. The reason being that if you think about golf, you're sort of following through on your swings. You've got repeated flexion going on there. Yeah, Kyle's demonstrating that very, very well. And with tennis, I think more about pulling back for a serve or something like that. Or yeah, even a backhand shot, you've got more repeated extension going on there. And that's why sort of those sports are associated or even named after those epicondylitis injuries. But yeah, again, a poorly worded question. We'll try and fix that afterwards and upload that for you as well.
So yeah, Janel sort of punished us on giving us that he's a golfer. But yeah, think about the local anatomy. Okay, outer part of the elbow. But also, yeah, I don't think Monash would do this to you. I don't think they'd give you a completely different buzzword and then ideally.
This is the most high yield question from this slide, so just keep that in mind as well.
Take the full 10 seconds if you need it. This is making up for the fact that we've messed up like 5 questions already. 3 marks.
I choose to interpret this as like a
I had a
favorite
couple
color
of messages. Sorry?
I choose to interpret this as like a favorite color poll.
Oh yeah. I guess
You guys
I don't
really
think
hate
there's a
green and you like
preference.
red.
I don't think there's a cohort preference. Everyone likes every single color, I guess.
Mm,
I
it's
think
statistically
the main
significant.
point, yeah. The main point for this question was just to show you that I got a couple of messages like 2 or 3 days ago from like 5 or 6 different students asking about like, do we need to know about the muscles of the foot? I guess because right now is the time when most of you guys are studying or restudying lower limb. The answer is no. I don't think you need to. I don't think we were ever asked any questions ever. I don't think we were even really that, like even in specimens and imaging, we didn't really have that much of a focus on these muscles. So don't really bother. I think some of the major ones, or at least the major things you want to know is just the innervation of some of those muscles. And I think there was a tutor that we had last year who was just kind of trying to draw analogies between the foot and the hand. So like the median nerve, ulnar nerve, how those kind of correspond to some of the nerves that are in the foot. So like the medial plantar, lateral plantar. But honestly, it's not at all high yield. Unless you want to become a surgeon, then sure.
Yeah, I'd suggest, if anything, just using some general reasoning. So going, okay, well, stuff that's on the plantar surface is going to be involved in doing sort of that gripping or flexion of the toes, versus extension of the toes will be something more superior on top of your foot. And thinking about like the anterior compartment is going to be dorsiflexing. Well, we should know the leg, so the leg, but the foot, yeah. Just vaguely clinically reason it, or take the hit on like if for some reason they threw a horrible question at you like this.
I see it's a toss-up between blue and red, but basically it's the fact that once you squeeze down on the carotid artery, you have your baroreceptors present in those carotid arteries. This will increase the pressure that's present there, which will increase the firing. So if you just remember, increased pressure, increased firing of your baroreceptors, and this causes increased activation of your parasympathetic system or your vagus nerve, and this causes a decrease in heart rate. So, or you can just think of it as person faints probably because low blood pressure, so drop in heart rate. Awesome. Just remember to remember where the vowels are. It's just using the mnemonic. Like, I think the one that I use is all prostitutes take money. And basically you remember where the top two are at the top and you got them in the second intercostal space and you got the fourth and fifth at the bottom. Sweet.
All right, this is what I expected with this question, because most people think stroke, they think a clot, they think clot's going to come from the varicose veins, which is true. But keep in mind that varicose veins are usually developing in your legs right? And we're talking about deep vein thrombosis in the legs. And while it is true that some of those potentially could go to the brain and or like to cerebral vessels, the most likely route for a clot from a varicose vein in the leg is usually going to be to the lungs. There isn't really any other way for it to spread to other parts because it's going to go from your legs, right, through the IVC, up to the heart and the right atrium, into the right ventricle, and into the pulmonary circulation. And because the pulmonary capillaries are there, it's probably going to lodge in them because they're very small vessels that it's going to get stuck in. So the most likely route for varicose vein caused clots is usually going to be in your lungs. And in fact, sort of what you will see online as well. However, a bit of an interesting point, which I only found out recently, is that if you have an atrial septal defect, like some sort of way for blood to go from your right atrium to your left atrium, it's kind of interesting because that means that your clot now is able to go up to the IVC, up to the right atrium, but now has a path to be entering the right ventricle, not the right ventricle, to be entering the left atrium from the right atrium, so across, right? And then from there, it can go into the left ventricle and then out into the systemic circulation, where it could somehow make its way to the cerebral vessels, from the aorta in the carotids. But again, if that doesn't make sense just yet, don't worry about it too much. Just have a look at a diagram of the blood flow that's occurring in the body and try and think about what's going to happen if I have a little gap in the septum between the atria and how it's going to allow that clot to spread from the right atrium to the left atrium and so on and so forth. But yeah, the answer here is going to be patent foraminal valley. Again, we explained why orange wasn't or yellow wasn't the answer. Red, aspirin is actually going to usually decrease the risk of stroke. And I think you guys have already gone over that in the, I think it was with atherosclerosis and lipid lowering. Erb's palsy, again, that's sort of not really related to stroke at all. It's actually to do more so with nerve damage and to do with effects in your, I guess, increasing the angle between your neck and your shoulder, not really important here. So the answer is going to be blue.
It's definitely quite a challenging question. You might be able to eliminate a couple of options, but yeah, it requires some reasoning.
I remember seeing this somewhere as it was like a university's like interview process. I think they actually asked this as a question to some of their students. This is the only way that I remember it because I was just looking at YouTube videos in year 12 because I had nothing better to do. So it's not really something you will come across in anatomy all that much, but it's really like the reason why it was posed as a question. I think what the reason why Jamie included it was just to show you the anatomy and like they're two separate circulations, but you can get situations where they can communicate somehow.
I don't expect them to ask you this, to be honest, because you're going to be learning more about varicose veins, learning more about pulmonary embolisms all next year. So don't be too alarmed if that doesn't make sense. See if you can try and piece it together with the anatomy. Otherwise, don't be too confused by it.
All right, you guys are experts at this. Nowhere near what I was last year, definitely, that's for sure. This is a two-part question. So remember that, I think it would generally be asked as two separate questions, but just remember that the lead 2, lead 3, and AVF, those are kind of pointing towards more of the inferior aspects of the heart. So they're called the inferior leads. And whenever you think about inferior leads, you're thinking about the right coronary artery. Again, think back to the anatomy in terms of what is the right coronary artery mainly supplying. It kind of goes downwards and of course to the inferior sides. I'd also have a look at, like, if you're ever confused in terms of like these sorts of questions, because they will come up at least one way or the other. If not the inferior leads, then the anterior leads or the lateral leads or things like that. If you're confused, just have a look at the slide deck that we've got up. That should clarify things a bit. But in this case, the right coronary artery will be the one that's affected. Cool. right, good stuff. Before I go on to this one, I just had a couple of questions for the previous one, which I'll address. So some of the questions were, why not the right marginal artery? That is true. So it does come off the right coronary artery. You just wouldn't see raised segments in all three of the leads that we've seen. It doesn't supply the entire inferior part of the heart. Again, you can have a look at the anatomy, but the right marginal branch is a minor branch that comes off the much more large right coronary artery. So you'd maybe expect one of those leads to be raised. And in general, that won't happen. It'll be all three leads, and then you'll know it's right coronary artery. Okay, so for this one, I think this is just bringing it back to some of the basic principles of ECGs. Remember that all leads should be, well, not inverted, they should be normal, apart from AVR. And the reason why is AVR, remember, is attached to the right wrist, and it's pointing in the opposite direction, or at least it's looking downwards at the heart from the top, whereas the heart is depolarizing downwards away from that lead. And remember, anything that goes towards that lead is going to be have a spike. Anything that's away from the lead is going to have a depression. So whenever the other leads are doing normal stuff, AVR is going to be doing the opposite, which is why it's not pathological for it to be reflected or inverted. Yes. Fantastic. Okay, so I don't think I was going to really like sit down and draw a diagram for this, but it feels like 50 of you got it right. So I might still do it just for like as a learning point, because cardiac axis calculations are quite difficult, and I don't think you will have like 10 seconds, 20 seconds to do it. You'll have longer. So feel free to like sit down and actually draw out the entire circle or the angles at which everything happens. But I'll just do a really quick annotation to show you what that looks like. So if you just kind of think about the views as being a sort of circle, and you think about these being the sort of quadrants that you're looking at, remember that when you start off, you're generally going to just be looking at lead 1 and lead AVF. They'll tell you the quadrant that is going to be correct. With lead 1, positive is going to be on, so if we're looking at it like this, the positive is going to be on the right-hand side, negative is going to be on the left-hand side. So if I have a positive lead 1, I know it's going to be this region here. So that's already good. With AVF, remember that that's at the foot, right? Which means that positive for the foot is going to be at the bottom, and then negative is going to be up at the top. So if we have a negative QRS, that means we're looking at this top bit. And obviously the overlap between those two sections is going to be just this region here. Now, the reason why I've included a lead 2 as well is because if you localize it to this particular quadrant, you can still have a chance that it's a normal cardiac axis. So you also want to look at lead 2, and lead 2 is a little bit strange. And I'll draw another line for this. Maybe it's like something like that is kind of where lead 2 or the axis of lead 2 is. And positive for lead 2 would be down here. Negative for lead 2 would be up there. So now that we've got a negative QRS in lead 2, we're just focusing on that red region there. And that is not normal. So if it was the other side, that would be a normal cardiac axis. This is a left axis deviation, which is why left axis deviation is correct. If you've already got a mental picture of this entire diagram in your mind, that's really good. But if you want to work on it from first principles, this is the way you would do it. For the other quadrants, you wouldn't bother with lead 2. Those would just be right axis deviation, extreme axis deviation, and so on. Great job.
Awesome source. So basically, with a 3rd degree AV block, we have complete closure of the AV node. So our SA signal cannot go down and modulate our ventricular pulse or our ventricular contraction. Therefore, we're reliant on only the Purkinje fibers, which fire around at between 40 and 60 beats per minute. But with only 40 as an option here, it is 40 beats per minute, and causing them to contract independently. Sweet. Nicely done. So basically with our heart, the only way to decrease heart rate is via the parasympathetics, and they only work on the SA and AV nodes. As we've had a heart transplant, this person no longer has that innervation present. Therefore, the only way to modulate the heart is upwards with the sympathetics, as it uses noradrenaline in the blood to increase the contractility and rate. Like,
Yes, fantastic. So just walking through all of these again, these are all signs of infective endocarditis, just to clarify, but they're all described slightly incorrectly except for orange. So with Janeway lesions, they're actually going to be relatively non-painful. And the way that you can remember this is Osler nodes are painful, so O for ouch. That gives you Osler nodes as being painful, Janeway not so much. Janeway lesions are because of the septic emboli lodging into the vasculature. The Osler nodes are more the inflammatory process, the acute inflammatory process. So those are not to do with the septic emboli directly. Finger clubbing, this is not something, I feel like this is a bit mean. It's not something you've covered so much yet. So you've studied finger clubbing in the context of IE, but finger clubbing is also really, really associated with a lot of lung pathologies. And I'm not going to go into those details because you'll cover that next year, but it's not extremely specific for just IE. And splinter hemorrhages are found on the nails. That one is definitely true. Cool. Yeah, perfect. Too easy for you guys. So remember that with the left-sided heart failure, all the blood is going to be backing up into the right system, or like the right cardiovascular system, which is the lungs mainly. So we're going to be seeing symptoms happening in the lungs. In other words, like mainly pulmonary edema. So anytime you're taking a history, and you would have learned this in clinical skills, you want to ask about how many pillows they might be sleeping on at night to judge like orthostatic hypertension. Sorry, not orthostatic hypertension. What's it called? Orthopnea, the one where you're lying down. Orthostatic hypertension is completely unrelated. Sorry about that. So sleeping on 3 pillows indicates you require a larger angle to be able to actually sleep comfortably. So all the water can sort of go down rather than throughout the lungs. Raised AVP, that's right-sided because everything's backing up into the left system. Again, pain in the calves is more to do with ischemia in the muscles and because of reduced blood supply. And then sensation of heart beating out of the chest, that's more like conductive problems in the heart. So something to do with the pacemaker cells or things like that. Well done.
Awesome. This is just another buzzwordy kind of one that Monash loves to give, which is basically IV drug user and infected endocarditis, and which heart valve is it most likely to affect, which is always tricuspid in this instance.
Lovely. So most people got that right. Yeah, some people chose Staphylococcus aureus, but for a dental procedure, the most common causative organism, or the one that's associated with it for Monash at least, is Viridans streptococci. The most common cause of infective endocarditis is IV drug use or being an inpatient, and that's from Staphylococcus aureus. Enterococci, enteric or entero means like of the intestines or of the GIT, the gastrointestinal tract. So if you've had a GI procedure or a GI infection, then you might have infective endocarditis from that. And coagulase negative staphylococci are for IV lines in a hospital or something. If you've had that, then you might have that specific causative organism. But definitely the two main ones are Viridans streptococci for dental and Staph aureus, most common, and you'll see it in IV drug users. It's always nice to see people crowd around their screens to read the tiny text boxes.
Nice, very good. So yeah, while multiple of these can cause some form of skin infection, the one that we typically associate with gas gangrene, which is what this is, so black bubble-like lesions, the one that's most closely associated with that is Clostridium Perfringens. Did anyone? I'm very glad nobody answered yellow, because varicella zoster is a virus, and so I'd be very concerned if we're getting a gram-positive bacteria in a culture.
Five more to go, guys. We're almost there.
It's coming down to the wire too, by the looks of it. Oh, okay, interesting. Okay, so glad nobody went for respiratory or foodborne there. Malaria is spread by a vector, i.e. Mosquitoes, and HSV is typically a skin-to-skin contact thing. Toxoplasmosis, so it's either like sort of a vector in terms of cats, which can bite you, or also it can be foodborne, typically not waterborne. Toxoplasmosis. So if your cat like walks in a food preparation area and then you eat the food, then it can infect you. But typically we don't see it in water sources. Norovirus, on the other hand, is very strongly associated with the fecal oral route. So that's one of your gastro bugs, basically, pretty common in that sort of infection. And so the natural life cycle of that virus is that it's going to be ingested by someone, cause the infection, then be excreted, and then go on to cause another infection. Yeah, we're getting down to the wire. This is nice. It's still competitive at the very end. So make sure you're doing your best in these last few questions.
Can someone, when you're not answering this question, tell me whether Rota or Norovirus, which age group you'd expect with each of those?
Awesome. So B12 and folate both are important in the spinal cord fusing correctly, and that's due to their presence within methylation of DNA. But because we live in the Western world and the idea of vitamin B12 deficiency is very unlikely, therefore the answer is folate.
But yeah, norovirus is more common in adults, and virus is common in younger ones. That's sort of how you differentiate them, because they have similar sort of difference to them. Okay, so which of these is not analytical in their study design? Lovely. So most people have gotten it right. So you must have been paying attention in my lecture or the lecturer's lecture. But yeah, so a case study is a lesser sort of quality study because you're just looking at one thing and you don't have a control group, which is what distinguishes analytical from what a case study is, which is descriptive. Descriptive study design. Select a question asking what are the limitations of RCTs? I tricked myself when I was going over this. So let's see how it goes. No, that's lovely. So some people fell for the same thing I did after writing this question myself. But most people didn't. So yeah, intervention can be unethical. So if you want to test that something causes a specific disease, then actually doing it might be quite problematic. And also it's one of the most expensive, I'd imagine, in terms of implementing. You have to get a lot of resources together to enable it. Blinding reducing placebo effect. I'm glad the fewest people selected that. That is true, but it's actually a benefit of our gold standard randomized control trial. And it's actually non-modifiable exposures that we can't implement. So if you think about it, modifiable, you can modify, so you can implement it. Whether it's ethical, that's a different question. But non-modifiable exposures would being impossible to implement, that would be a limitation of randomized control trial. It is really incredibly close, 400 points between the top two. What distinguishes retrospective cohort studies from case control studies? This is the real test of whether you me during my low yield or just one pop lecture study design. How'd we go there? Wonderful. Most people got it right. The majority of people got it right. So yeah, case controls start with the disease and then they look backwards in time to see what were people exposed to that might have caused this disease. And with a retrospective cohort study, you start with the exposure. And with any cohort study, you start with the exposure and then you either look back in a retrospective cohort study or look forward in a prospective cohort study to see what are the what are the effects of that exposure. So I suppose even in a retrospective cohort study, it's that you're looking back and the outcome has already occurred. So you're looking back, exposure, and sort of looking forward, but they're both looking back in time. That's what sort of confuses the two, retrospective cohort and case control. I hope that makes sense. Message me if it doesn't.
Oh, holding on by a thread here.
And on to our final question.
Yeah, will it be crying
401
emoticon?
points.
Yeah, will it be crying emoticon or double S? Who knows? Better pay attention. This is the hardest question of the entire thing.
Very challenging.
It's not Kyle, Deepak, or James though, which is worrying.
Yeah,
None of you guys came first.
that reflects poorly on us, guys. But I appreciate that someone named themselves us. Okay, so yeah, P's get degrees. Is it true or false? Do P's get degrees? Does P equal to B med sci / MD? I'm resentful of the fact that no was not the least, but I agree with the angry sort of displeased emoji. Now, so yeah, yes, P's get degrees. Marks aren't as important as your enjoyment or your mental health. So make sure that you're taking, or your physical health, or anything real, or any sort of vestige or parameter of your health. Taking care of yourself is the most important. It will enable you to pass, definitely, and really, especially first year. Just get through it. It gets more and more clinically relevant as we progress through the course, and yeah, make the most, as I can see through some of these video screens. Make the most of being able to be around other people now. That's what's most important. Thank you.
All of our podium people were at the top at one point or close to it. So well done to all of you guys. And especially to Crying Emoticon, if you're willing to reveal yourself, if I ever see you on campus, I'll find some appropriate prize to give you. But yeah, no, thanks everyone. We're keeping it open. We'll stop recording it and then open it up to Q&A if you guys have any questions. And we will keep this one publicly available if you want to go through it again for your own revision. But that's pretty much all for us this year. So thank you so much for a great year and have a great break. Best of luck for exams.
Best of luck, everyone.
Love you, PSPlatypus.
Thank you.
Thank you. Good luck, everyone.
Good luck, everyone.
Thanks so much.